Because statin intolerance it can occur to up to 25% of the patient population. In my clinic per se, I specialize in this. Over 50% of the patients referred to my clinic have some form of statin intolerance. So what we did is we had patients who were intolerant to at least 2 statins or more, and one of the statins had to be the lowest daily dose of that statin prescribed. And in order to validate their statin intolerance, because it's a complex disease and difficult to diagnose, we had 3 validating arms. One, we had a 4-week placebo-controlled, double-blinded run-in period of 4 weeks, where we found 13% of patients dropped out. And of those 13, a majority dropped out because they had myalgias from placebo. You understand how complex it is. Then we went into the 24-week blinded arm with 3 arms. One was alirocumab 75 or 150 milligrams every Q2 weeks injectable, and it was changed to 150 if their LDL was not at goal by week 12 of the 24-week. The second arm was ezetimibe, 110 milligrams a day with a placebo injection. Why ezetimibe? It's usually the drug of choice that's used for statin intolerant patients. And then third, as another validator, we used atorvastatin. We had a real statin in the arm, 20 milligrams a day, along with a placebo injection. And we followed them for 24 weeks. The primary endpoint was looking at efficacy between ezetimibe and alirocumab. And we found in the intention to treat arm at the end that the LDL reduction was 45% with alirocumab, with only 14.6% with Zetia, and 50% of the patients on alirocumab had to elevate their levels to 150 milligrams per 2 weeks because they weren't at goal. And efficacy also showed that about 42% of the patients on alirocumab got to goal, where they needed to go, compared to only 4% on ezetimibe. By the way, the 20 milligrams of atorvastatin lowered LDL by 32%. One, 80% of patients on all 3 arms had a complaint of some kind. And the dropout rate was from 18 on alirocumab all the way up to 25% on the atorvastatin arm. So it's telling you, patients who couldn't tolerate statins, 75% still could tolerate atorvastatin. The significance between the 3 was not enough, but there was a trend. When we broke down the AEs to musculoskeletal, because that was really the ones we wanted to look at, because that's the most common side effect, we found a significant difference between alirocumab and atorvastatin. There was a difference, but the dropout related to myalgias was not any different. There was a trend, but not different. So finally, we go into the 3rd arm. If everyone finished the first 2 segments, they were allowed to go into the 3rd arm, which was giving alirocumab to everybody, open label, for 3 years. And we have interim analysis of that. And about 90% of the patients went into this. Now, I didn't tell you about this patient population, but over 50% of them had cardiovascular disease. 20% had diabetes, and their LDL at baseline was 190. So this is a high-risk patient population. So the safety analysis in the open label changed dramatically. Only 50% or so complained of adverse side effects, and less than 3% dropped out. So from a patient population 100% intolerant to statins, in the open label, 97% were able to tolerate alirocumab and be treated. And of those, as I said, over 50% got to their goal. Well, I think the 75% of patients who were on atorvastatin tolerated it was a surprise. The 25% that were on ezetimibe couldn't tolerate ezetimibe. That was somewhat of a surprise. But the good surprise was in the open label, where 97% of them were able to tolerate alirocumab. That was a positive surprise. Again, statin intolerance, the classic is muscle aches and pains, but there are so many different levels of intolerance, from insomnia to depression to a rash. It's so diverse. And clinicians know this. They see it all the time. And it's difficult because you feel like it's not a drug, but the patient tells you it is. And the patient's the bottom line. You're treating them. If they say they don't want to take it, they're not going to take it. It's a light at the end of the tunnel of this patient population. This patient population is so inconsistent, difficult to diagnose, as I said, and more importantly, difficult to treat, that if you have an LDL 190, you're not going to get to goal by giving a statin once a week or something like that. You need something powerful. And it looks like this class might be the answer for that population that can't take standard medical management that's going on now, in this case, the statins. It's a step. I mean, the drug's not been approved by the FDA, so we still have to wait for approval. They've submitted, some companies have submitted, and they might hear by sometime mid next year or late next year approval. But the true value will be outcome studies. And this Odyssey program, which there are 14 phase 3 trials, one of them has an 18,000 patient study of looking at hard endpoints. And when that study is done and that shows benefit by reducing LDL with alirocumab on top of a statin, then we'll have the data to say, yes, we do have this class that is quite effective in lowering LDL and, more importantly, lowering cardiovascular disease. Personally speaking, to my patients that participated in this trial, now that they're in the open label, they come back now on a regular basis to get follow-ups. They know their level of LDL because they've been shown it, and they aren't having any side effects, and they're so ecstatic because this is the first time in their whole life, some of them, they've gotten their LDLs to goal, and they're very, very happy that they've done this.